Hello, and welcome to our TraumaCad Orthopedic webinar series. Thank you all for joining us today. My name is Christina Terrell, and I'm an account manager for the North American TraumaCad team. TraumaCad has been templating for over 20 years and is installed in thousands of sites across the world, including Southern Joint Replacement Institute. If you have any questions as the webinar progresses, please submit them in the chat and we'll answer your questions at the end. For now, I am very excited to introduce our speaker, Stephanie Chambers.
Hi, welcome. My name is Stephanie Chambers. I am honored to be here. Thankful to TraumaCad and Brain Lab for inviting me to do this webinar. So thank you for spending your time with me this afternoon. And just a little bit about me. I am a surgical tech by trade, and I have been in orthopedics for almost 20 years. I am currently working in the office for 8 busy joint replacement surgeons in Nashville. And I also serve as the fellowship coordinator. We annually have 2 fellows per year. And I also serve as the director of the nonprofit Walk Strong Foundation that was founded by our surgeons in 2010. That nonprofit is just something that we help build sustainable joint replacement programs across the world. We are currently in 6 countries, and I have helped some of those non-physicians and physicians learn how to do templating with TraumaCad. Currently, our surgeons do about 4,300 cases per year. 25% of that volume is revision surgery, and I think that we average about 70 to 90 cases per week, and that is how many I template. Many questions that I get asked is, why would the surgeons let me plan their cases? Why would they trust me to template? And I understand why you might be asking yourself that. Like I said, I've been with this group for nearly 19 years and started out in the OR with them as a scrub tech, and I enjoyed scrubbing the hard cases. I wanted to scrub all the revisions. I enjoyed the challenge and being able to anticipate and understanding the why behind the cases. Most of the time I enjoyed the fellows being in the room, but mostly because they were teaching during that time. They were talking and I got to listen, and I appreciated hearing the why behind what we were doing. They've built a team of people and put the right people in the right place. And so that this allows them to focus on the surgery and the training and seeing the patients in clinic. So today, I am just going to run through some hips and knees and some complex cases and show you a little bit about what TraumaCad has to offer and why templating plays a part in planning and plays a part in accuracy and efficiency. And then we'll jump into a live template of templating a hip. This case is a 90-year-old man who presented in clinic with an untreated femoral neck fracture. And the reason it was untreated is because he was not medically stable for surgery at the time of his fracture. And so it went untreated for about 3 months. And I do want to say that my physicians have granted me access to show their cases as long as I keep the patient information out. So, but this was a recent case, and this particular surgeon, when I go into planning, I try to think about the preferences of each of the surgeons, because of course they all do things different. They all use different implants. And so I have to really remind myself who I'm focusing on in the moment and what they want to know about the case when we go into planning. So with this being a 90-year-old man, I am thinking about bone quality. And if this patient is door A, B, or C, and is this physician someone who might cement a hip, or does he use a press fit? Is he going to be doing this anterior or posterior? We can see that this patient has a second side hip. And is this a hip that we did in our practice? Is this relevant information that the surgeon would want to know? And in this case, it's not. But it's good to know that, and he probably wants to know where it was done. With that said, I start thinking about the leg length. And obviously there's clearly a leg length discrepancy, and we'll get into that on the next slide. So this is the templated view of this x-ray. And again, this surgeon, when I approach this, one of the first things he wants to know is what size is the native head? And here, of course, we can't see that. And we know that that's a bit of a challenge. And so I would normally use a Mohs circle that's offered in TraumaCad to measure the native head. In this case, I used a ruler to just guess. And you can see that over the where I wrote native head with a question mark. So he can know that I truly was guessing. And then I did measure the cup on the other side. I felt like that cup was probably appropriately sized or close. And I measured that to give him a little bit of guidance. He likes to know that so that he can get an idea of where he wants to start reaming and what size to ream with. And it gives him an idea of knowing about what his cup size may end up as. So yeah, and then measuring the leg length. TraumaCad offers an automated leg length. And so if the landmarks are identifiable, then TraumaCad does a great job of automating those leg lengths and getting an idea. However, if you have a more diseased hip and the landmarks are rotated, then TraumaCad does struggle to find those landmarks, and you can easily go and manipulate them how you need to figure out your leg length. So then you can notice also on the cup placement that there is a degree above that shows you your abduction, and that is typically at 40. I have a surgeon who sometimes likes a flatter cup, and he'd like to see that around 36 or 38. And of course, sometimes it plays a part whether it's anterior or posterior. After placing the cup, it gives me an idea of where I'm going to place that stem next. And with that said, they like to see a neck cut measured from the lesser to the collar. And I know that their guideline is 10 millimeters and between 10 millimeters and 20 millimeters. And so if I'm in between those numbers, I think I am pretty close in where they want to be. You notice that I have written a lot of notes on there for him, and there is a feature where I can blow that font up, and I know that they appreciate this so that when they're standing at the operating room table, they can see the monitor in the room and read the notes that I've provided for them. And on the next slide, I have put the post-op image compared to the template. I would call this a little bit of a win for me. I think that when you're looking at the placement of the post-op, that maybe the only difference or similar difference is that there is a smaller cup. This surgeon does tend to go with a smaller cup. But is that because of the bone quality? He typically is a one screw in the cup kind of guy, but he used two here. So that makes me question maybe whether or not the cup was as stable as he wanted it to be. So he probably medialized it a little bit more and put a couple of screws in. Anyhow, I call this an overall win for the placement and the neck cut and all those things. Another feature that that TraumaCad offers and that I utilize for planning case purposes, this is a DDH hip case. We often, for most of our cases, get a long leg film. Long leg films are a special software. I know if you have that control in your X-ray department. Luckily, we were able to get that software, and we use it frequently. And so for this specific DDH case, I'm able to tell a story, and I think that this conversation gets brought up often in our indications conferences with our fellows, and often in some of our pre-op meetings. It's discussed. If you look at the AP view, you can see that it's showing a 46 millimeter difference in leg length. And when you look at the or the long leg standing view, it's only showing about 15 millimeters difference. Lucky for me, I don't have to decide which is correct. That gets to be up to the surgeon. I'm just here to tell the story and show the differences. You can see that I like colors, and I change the colors so that they can see the differences in the what I've tried to measure for them. Right is always on red and blue on left, just like your tourniquets. And yeah, so they get to tell the story, and hopefully in clinic, they put their patient on blocks and maybe had a discussion with the patient of how short they feel, and maybe that also plays a part in it. But for the sake of templating, I just try to tell the story of seeing both options. In addition, on these harder cases, one of my favorite options in TraumaCad is being able to duplicate the images of the implant, especially on these more diseased hips, and they're rotated. And I know that when I place the template on the hip, that it is not giving me a clear view of what that's actually going to look like. So I will duplicate it and flip it over to the contralateral hip to get a better idea of the fit and size, which gives me a little bit more confidence when I do place it on the diseased hip of is this really going to work? Is it not going to work? And it allows me to raise questions with the physicians and concerns. And when I bring questions and concerns to the physicians, they do listen, and they want to know, because they have put so much trust in me that if I'm going to raise the question, they listen. So for this hip, I would say, is this the right implant for this case? And I did raise this question: is this going to be done anterior versus posterior? This particular surgeon is a big anterior guy, and he chose to do this anterior. And so I have follow-up questions of, are you going to need augments for the cup? Are you going to need a femoral eyebrow graft, and to use the femoral native head? And is this the right stem for this DDH? Do you need to do a shortening osteotomy in order to get that leg length back? So lots of questions come up when I'm templating, and it allows me to understand the case a little bit more and bring to their attention. The next slide, knees. I'm sure many of you may be saying, I'm not going to waste my time templating knees. It's not that important. And I want to bring to the attention it is important, and why it's important. It takes less than 5 minutes to template a knee. It can be super quick. But I think that oftentimes I see, because of the amount of revisions that come through our office, oftentimes I see a case that I start templating a revision for, and I start recognizing that the sizing is very small, and it doesn't match what's currently in, that something's off. And I quickly recognize that they didn't have the right size implants in the surgery, and they didn't do any planning for that surgery. I know what most of the implants are on the shelf in our hospital, and I work so closely with the vendors that I know that these micro and macro sizing needs a special order in. It's very common for the common sizes to be on the shelf, no problem. But when you start running into the macro and micro sizing, I know that those are special orders. In addition to that, if you are a high volume practice and you have multiple surgeons that use maybe the same implant, or maybe you operate both at a hospital and an ASC down the street, that it's very common that maybe there's 6 right knees in the same day, and they're all templated size 5 or 6. And I can tell you that that requires some more ordering of not only the implants, but the instruments. And maybe your ASC breaks your instruments down to sizing. Maybe this helps your scrub tech be more efficient. This is all to make the surgeon's day better, accurate, so that they can focus on the things that are important and not the things that are going to frustrate them in the moments, and realize that they don't have what they need. And if you are a surgeon that's in a more rural area, this still applies because I'm sure that the inventory even is less. So knowing what's in the hospital is helpful. And if you don't know what's in the hospital, it's just better to know what sizes you have for the amount of cases that you do in each day. And if you're a robot guy and if you use robots and you go, oh, I don't need a template because I use the Mako. Maybe that is true. And the Mako is the only robot that does the CT pre-op planning. And make sure that if that's the case, that your Mako specialist is communicating with the person who's actually ordering the implants. Here in our hospital, we have a rep and we have a Mako specialist, and making sure they're communicating when that one plans it and he communicates it to his rep. I hope that does happen. And if not, it needs to happen. And then, of course, with your Veluses and Cories, there's not pre-op planning. So the same principles still apply, in my opinion. And again, it takes 5 minutes to template knees. Location of marker balls and the calibration. I didn't touch on this with the hips, but the same rules apply, that you want to just make sure that your x-ray techs know the proper placement of those marker balls, so that calibration is accurate during templating. It always needs to be in the joint line, not behind, laying on the bed or on top of the patient, and that it's as close to the joint as it can be, just within line with the joint. And then for fun, I showed the post-op of this because I am still getting used to the new crooked KA knee. But the patients do great, and this is just the post-op film. In addition to templating knees, this is a long leg film that I mark. My surgeons are 50-50 with which line that they prefer marked, whether it be the joint line or the long leg resection line. The joint line just allows them a chance to kind of eyeball whether their tibia cut is going to be in varus or valgus for when they put the tibia jig on there, and they have at least an eyeball view of where they want to start, their starting point is. With the long leg resection, it's more for mechanical axis. It also shows the tibia line, but in addition, it shows your distal cutting jig and where you want, what degree you want it at. I know most surgeons will say it's 5 degrees every time, but maybe this shows you that the hip is sitting in more varus or valgus than it should be, or that it for normal anatomy. And this can help you decide if you need to adjust that distal cutting jig to 6 degrees or 4 degrees or 7 degrees. I also use the joint line on revisions for neutral tibia placement if the tibia is in neutral, and if not, if there is a question about revising the tibia or leaving it, this also can show if they think the tibia is in the proper placement. And then I just threw in a couple of fun, complex, recent revision cases that we've done, just to show some of the tricks of TraumaCAD. I clearly love colors to differentiate between each modular implant, or just to show a differentiation of each implant. For hips and hip revisions, it is often that I am duplicating the image or showing 2 different stems for length if they wanted to bypass the current stem further or not. And then the revision knees, the cones, adding cones, and also deciding whether or not DFR or a hinge is going to be appropriate. So yeah, oftentimes I'm just trying to tell a story to the surgeon, and for them to determine whether or not the plan that they think they have in place is in fact the plan they want to follow through with. So with that said, we can jump into the templating session. And this is a demo hip that I will be using from TraumaCAD. So once you've selected, TraumaCad is pretty user-friendly. If I click too fast, I apologize. I try to slow myself down. If you have used TraumaCad, you already know that. Today, we're going to be working on the left hip. And you see that it automatically calibrated. But before I hit accept, I'll show you that you can manually calibrate. If you know that your marker ball is the 28 or a 32 or not a 25, this allows you to change it. Select the circle and then go find that marker ball and make sure that it's sized appropriately and accept. The other feature for oversize, I use this a lot when we have emergency add-ons come through and images are taken elsewhere without the calibration marker. And my typical rule of thumb is 115 degrees oversized to get that accuracy. So the first step is which surgeon am I working on? My very favorite feature in TraumaCad is the kits. So there are two ways to find implants. And first you would select the manufacturer here. And then you would type in, if I select, we'll go with the common, widely used DePuy, and then you're able to select your cup and then come through and select your stem. But my favorite feature is the kits. So I pre-planned where I could select the kit and favorite it. So every time I come into TraumaCad, this helps and allows me to be more efficient. So if you're using the same implant over and over, I highly recommend doing that so you're not searching your implants every time.
Stephanie, really quickly, I just wanted to make a comment that if anybody has questions about anything we've talked about so far or about the templating, please put it in the chat. And then when Stephanie wraps up this templating demo, we will answer your questions. Thank you.
Okay. So the first thing I do is I always want to move the numbers off the bone, get an idea of what I'm looking at, and start with the leg length. Leg length, you can see the leg length line did automate. Oftentimes I move it because the surgeons I work for like to see it up at the top where they call it the ski slope, because usually that is the most identifiable even when the legs are rotated and you're looking for the same landmarks on both legs or hips. I also have the preference of whether they like to see this line under the obturators versus under the teardrops. If you have a hard time seeing where the teardrops are, you can zoom. I zoom in very frequently. And for the time being, I will leave it under the teardrops as I work on my next step of placing the cup. I'm always told to start with the cup and that the neck cut is always determined on the placement of your cup. And so before placing the cup, this is the Mohs circle that I was talking about earlier. And I, of course, will zoom in. And I will try to get a good size of what we think this cup should be. I'm noticing that the oversize is at 100. So when I messed around with the calibration beforehand, I think that it messed up, but I think this is good because we can go look and see that if we are in doubt of what that calibration is, you can always go back and change and adjust. So if you go over here to the left side and hit image, it takes you back to that original screen where it thought that I wanted to stay at the oversize. So I'm going to go back to this automatic, hit accept, and it changed and adjusted to the mag that it should be. So with that said, the femoral head is measuring about 54. Again, I increase these numbers for the surgeons. And I'm going to label what this one is so that he knows. And I'm also going to change the color because I like to change the colors. Oops, not of that. I apologize. I want to keep that one black. And I'm going to change the color of the actual measurement. And then I want to increase the font, depending on how big your screens are in the operating room. That can be up to you. Just increase them all. Okay, so we know that the head is 53 millimeters, 54 millimeters. Everybody has their preference. I think that my surgeons would typically tell me that their cup is going to be 4 to 6 millimeters bigger. Anterior, they typically will go smaller on the cup side. So if we're at a 54, I'm going to start at a 58. I'm going to get the cup as medialized to the teardrop as it needs to be, and I'm going to put my adduction to 40. And then I'm going to try to decide, am I happy with that 58? Should I go bigger? And the good news is you get to play around with it and go bigger if you want. Now, the other feature that I love and use all the time is this is where I would duplicate it. There's the button up here to duplicate that. And I flip it because I want to go look at it on the contralateral hip. I want to see if that sizing also looks good over there. And I understand that they're not the same, but it gives me an idea if I think that this is an appropriate side of what the hip once was. So I'm going to increase it to a 60, and I feel happy about that. I'm going to raise it up. I think that I always shoot for the base of the cup to be right around the teardrop or right below this line. And then I can move to the stem to place the stem. Paying attention to these numbers right here, this is TraumaCad automates the placement of the stem. So if I move it up or down, it can show you where I'm trying to correct the leg length here and also get this offset to 0. If we're looking at the x-ray, we recognize that the offset is a little less here and a little more increased here. My rule of thumb is that I try to keep the offset always at 0 because I don't want to increase it and I don't want to decrease it for stability purposes, all the things. So I can go play around with the sizing. I think that immediately, because I have medialized the cup so much, I want to go with a high offset stem. And there's a lot of ways that you can manipulate this stem, whether it is to rotate it using this dot here. And maybe my mouse is creating too much movement, and you can use your arrows on your keyboard for more fine movements. My leg length was telling me that I'm 1 millimeter short, so I want to gain a millimeter here. And I'm still showing -3 of offset. I'm not positioned exactly right here. I'm in the cortex, so I'm going to use my arrows to reposition and to center it. And let's see, still -1 off. And again, I'm not completely upset about that. I can probably move it another millimeter, maybe move the cup, whoops, another millimeter back. I would probably be happy with this placement for the surgeon purposes. And then I would zoom in for my neck measurement to know where they want to start with their neck cut. I'm going to change the color, and I'm going to make the font bigger. And I'm going to move it off the bone. And I am in the parameters and the guidelines that they give me of that 10 to 20 millimeter goal. And then I would move. So TraumaCad offers annotation where when you go to save the case, it will tell you what implants you've selected. I typically like to create my own notes and make it big. Sometimes my surgeons will mismatch and use a biomet cup with a DePuy stem, or if we're doing revisions, maybe I need to add additional notes. For the purpose of today, whoops. And I would blow up the font bigger so they can see it in the OR. And then I would go to the report and save the case here. You can also go to file up here and save the case right at the top. And then you want to just make sure you're selecting your PACS, which I'm not connected to PACS, so I can't select it. And then that annotation we talked about is here. It will automate, and you have the option to move it around the screen to get it off of the bone, or you can select none for it to say none. Is there any other features? There is a back button. I do love the back button. If I think that I like an X-ray, or a placement, but I want to go try another stem, I can go add a stem and see, do I really love the Actus? And maybe I want to try a Cone Wagner. So I'll go select the Zimmer Cone Wagner. You can search through the library this way. And I don't use this feature often, but I know that you can type in Wagner and it pulls right up. And my Actus stem disappeared. So with that back feature, if I decide once I put this Wagner stem on there and I don't like it, I can hit the back button and my Actus stem comes back. Now, what if I want to have both of them up there at the same time? I've figured out a workaround, and I can duplicate this, save my duplicate, delete this old one, and go back and add the Cone Wagner stem. And then maybe I change the color so that I can show the surgeon the differences of what they look like in that way as well. Any other features? I think that those are my favorites, and that's going to conclude templating a hip. I hope that you all asked me questions. In case I did forget something, I'd be happy to answer any questions.
We have a couple of questions.
Okay.
In which cases do you usually check your post-op image?
Well, often I tell myself no news is good news. So if I have not heard from the surgeon, or if I have not heard from a rep in a room, then I say that it was a win. However, on revisions and cases that I spent more time on and I really want to know, I will go back and check x-rays or implant logs. And oftentimes I am following up with the reps during cases to see how things are going.
Thank you. And then what is your rule of thumb for bone length measurements and angles?
My rule of thumb for bone length measurements. I'm not sure I have a rule of thumb. I know particularly on knees, if it were a uni, I am very much not marking the measurements that I showed previously, but maybe I'm just using a ruler to measure from the head center all the way to the mid talus. I do this often on unis just to make sure that we are in varus or valgus and that we're doing a medial uni versus a lateral uni. I think too, I'm always checking for valgus deformities on knees just to make sure that we are going to be using standard PS or CR implants, and that something of a revision style implant is not necessary. And then, of course, the comparisons for the hips, I often use the long leg bone lengths to gain accuracy or to tell that story further for the AP versus long leg lengths.
Wonderful. And I love your changing of colors so that you can see those different measurements nicely on the templating as well.
Thank you.
Thank you. So last question I have so far, unless anybody else wants to add a question in, what is your advice for ensuring that X-ray staff places your calibration devices accurately? I think this is an important question too.
It is important, and we are so lucky here at where I work because the radiology techs are employees with the practice. So I do think that we have a benefit of consistency and that they do this every day. I think that our X-ray techs are pretty phenomenal, and they template. I mean, they X-ray probably 80 to 100 patients a day, and they have gotten really good at placing that marker ball. And again, they have provided images to us for placement. And I've sent these images to some of our foundation countries so that they know the accuracy of how to place those marker balls. We've gotten creative because TraumaCad does give you, I forgot the name of the device, the King Mark, or is that right, Christina? The King Mark that comes on a platform with the calibration ball. And some of our locations have gotten really good at just using the ball on taping it to the top of a highlighter so that they can gain the access on the patient correctly and make sure that they're in midline with the joint.
Wonderful. I love that they get creative too.
Yes.
That's great. Okay, and then I was wondering if you could talk a little bit about how this process in TraumaCAD ties into OR setup.
Absolutely. I think that, the trays that are pulled for cases and the inventory that's in house, it absolutely plays a part into it. So part of the planning for my team is I take what is on the template and I put it on a packet that I send to the OR. So if we are doing 80 cases a week, I am sending 80 packets to the OR every single week that has very detailed information for each patient. Not only that, I have a standing Thursday meeting with the OR management team, and we go through the cases with our schedulers and our mid-levels to make sure that everything is accurate and ready for surgery. But they take that information from the packet with the sizing and the vendors. They put it into their OR control, which is their OR board. And this allows not only their staff to see, but the vendors to see. In our office, I also have a communication tool for my vendors. And I, instead of emailing or texting them, I worked with HCA to develop a process where it automatically emails them from a system that I use, and they're able to check this daily to see if there's any changes. And it's just the volume is just too much to not be able to be more precise than just a text or an email. And with all the reschedules or cancellations or add-ons, it's been very beneficial. So this allows the OR and the reps to be ready and have enough trays on standby. And I think that they pull the cases and pull the trays the night before, but I think that's pretty common practice.
So that is all for the questions. Stephanie, thank you so much for being here tonight. It was extremely impactful to see your planning process that you go through and how you take into consideration how each of the surgeons like to template and like to see their implants. So it was wonderful. Thank you so much for being here.
Thanks for having me. I really appreciate it.
You're welcome. And thank you all very much for joining.